On the behalf of SOE, I would like to welcome you to the SOE webinar on 2 a.m. ocular emergencies. Before we start, I would like to express our deep sadness and concern about the recent events in Ukraine. So, firstly, I want to run through some quick housekeeping items regarding the audience questions. You can ask questions via the quick Q&A section, and we will be looking at them and trying to answer them as much as possible and as many audience questions as possible. So if you have a particular question after this webinar that wasn't answered, please email it to soawebinars@soavision.org, and we will try and answer them in a separate document, which will then be accessed via the SOA website. So I would like to remind you that this webinar is being recorded and will be available later via the SOA website and placed on the SOA YouTube channel. I would also just like to talk you through the running order for today, and this webinar will be split into 4 sections. First is acute painful vision loss, the second one is acute painless vision loss, and third one will be ocular traumas, and the fourth and the last one will be orbit and optic nerves and palsies. Within each section, each talk will be presented as quick fire rounds, followed by a Q&A session at the end. And if you would like to ask a question, simply submit it via the Q&A section on Zoom. Thank you very much, and let's move on to the first section. And Simon, the microphone is yours. Thank you very much.
Thank you. So we'll begin the first session of the webinar on acute painful vision loss. There will be 3 presentations followed by time for Q&A or discussion as introduced by Murat earlier. The presentations will be given by, first of all, Angela Panico from Italy, discussing microbial keratitis, followed by Zeynep Aktas from Turkey, discussing angle closure glaucoma, the acute management, and finally by Florence Huckwild from Switzerland, discussing acute anterior uveitis differentials and assessment. So we'll kick off.
The microbial keratitis are infections of the cornea associated with signs of inflammation caused by bacteria, fungi, viruses, parasites, and protozoa. The early symptoms are discomfort, dry and irritated eyes, foreign body sensation, watering, and eyelid swelling. The early symptoms increase with the time and then occur severe pain, photophobia, discharge, and blurred vision. The signs are infiltrates in the corneal stroma with or without epithelial defect, signs of inflammation from redness to hypopion. The first step of diagnostic workup is the clinical history to investigate the risk factor, in particular the contact lens wearing, the exposure to contaminated water, traumas, and comorbidities. The examination of the eye starts from check the visual acuity for medical and for potentially legal reasons, then check the eyelid to find out abnormalities predisposing to keratitis and fornix under the upper eyelid, looking for conjunctival foreign bodies. Then the examination of the conjunctiva, that could be swelling, could have the discharge, and the injection of the conjunctiva could be diffuse or sectorial. The aspect of the cornea, in particular the size and the shape of the epithelial defect and of the infiltrate, that could be single and central or peripheral and sometimes multiple. The examination of the corneal is important to find out the signs of a pre-existing condition, such as foreign bodies, scars, especially in case of recurrent herpetic keratitis, where we can find a corneal anesthesia. Then the inspection of the anterior chamber. In the anterior chamber, we could have an inflammatory reaction with hypopion. The hypopion could be sterile, sign of inflammatory reaction, or infected, sign of a spread intraocular infection. Now let's go see key features to direct the clinical differential diagnosis. In case of a viral keratitis, the pain is mild, the vision is slightly blurred, the discharge is watery, and the infiltrates of the cornea has the characteristic features after fluorescein staining, arborescent. In case of bacterial or fungal, the pain is mild to severe, the vision is very blurred, the discharge is purulent, and the infiltrate of the cornea are wide, whitish or yellowish, sometimes single, sometimes multiple. In case of acanthamoebal, the pain is mild to moderate and disproportionate to clinical sign. The vision is blurred, the infiltrate are non-responsive to usual antibiotics drops, and the typically ring shape is only in the conclamated stage. It's impossible to be certain whether the cause of keratitis is bacterial, fungal, or acanthamoebal. The corneal scraping is necessary to do the microbial examination and to have the exact microbial diagnosis and to check the sensitivity of the antimicrobial drugs. So the keratitis are emergencies because of the risk of potential loss of the vision of the eye or of the eye. And as earlier is the diagnosis and more targeted the therapy, as lower is the risk of permanent complication. And a crucial rule as a prevention to inform the patient about the risk, especially those of the incorrect wearing of the contact lens, reduce the risk of onset of a severe keratitis. I would to thank you for your attention and I wish you a good evening.
Dear colleagues, this is Zeynep Aktas from Turkey. And I'm going to present 43-year-old female patient presented with pain and redness and decreased vision in the left eye. She had a history of recurrent intermittent eye and forehead pain together with retinitis pigmentosa. As you see here in your left eye, she has severe corneal edema, shallow AC, and pupil was mid-dilated and intraocular pressure was 52 millimeters mercury, and in the right eye, AC was shallow too. With this clinical picture, patient was considered as primary angle closure glaucoma. IV Retinal was given, and we put her on Pilo along with ecosuppressants and steroids to make the eye ready for LPI. And then LPI was done. And as you see here in these UVM images, there is a combined mechanism here in this case, pupillary block together with anteriorly located ciliary body. And you can also see here the absence of ciliary sulcus. And in the second day, you see here the LPI was very small and intraocular pressure was 20/20, and there are some descending membrane folds. And here you see the patient's follow-up on 5th day, IOP was 19 millimeters mercury, and on 10th day, IOP tended to rise again. It was 23 millimeters mercury. And after the LPI, as you see here in this UVM images, the letter iris configuration is more clear. Here, AC is still shallow, and other than that, axial length was 18 millimeters. And on gonioscopy, there was a double hemiappearance, which is typical of plateau iris bilaterally. You can also see here anterior chamber is very shallow, 1.2 millimeters. On the other hand, on OCT, there was no retinal nerve fiber layer defect. Fundoscopy revealed typical retinitis pigmentosa appearance characterized by attenuated vessels, bony spicles, and waxy pallor. Since the patient has a recurrent angle closure attacks, short axial length, together with uncontrolled intraocular pressure, cataract extraction was done here in this case. And we are trying to maintain anterior chamber in this high-risk case. And taking the lens out, and after the lens implantation, at the end of the surgery, we did iridescent highlighter vitrectomy, since this eye has a high risk for development of malignant glaucoma. Here in this slide, you see the preoperative and postoperative change in anterior chamber depth. And here, postoperatively, intraocular pressure was 13 millimeter mercury. And right after the cataract surgery, as you can see here, anterior chamber depth was increased to 2.74 millimeters. And this is the postoperative appearance of the patient. And on the left-hand side is the right after the operation. You can see the decimal membrane folds. And on the right-hand side, you can see the postoperative first-year follow-up of the patient. IOP was 60 millimeter mercury unmedicated, and visual acuity was 20/20. So in these cases with retinitis pigmentosa, there might be combined mechanisms of angle closure, like zonular laxity, plateau iris, and pupillary block. And imaging like UVM in these cases is of paramount importance. And generally, pupillary block is the most common mechanism. And medical treatment and LPI, generally the first approach. On the other hand, lensectomy can be done at first place, according to Eagle's study. Short axial length is one of the most important risk factors for the development of postoperative malignant glaucoma. To prevent this complication, iridozonal highlighter vitrectomy might be done. And timely intervention can prevent further damage in these high-risk cases. Thanks for your attention.
Hello, everyone. Welcome to this webinar. So I'm going to present a case of anterior uveitis. It's a 59-year-old male who came with the ER with the straightforward history of red painful eyes in 3 days. He had no relevant medical history. So the status was like that. There was granulomatous precipitates and acute uveitis with inflammation, and the fundus was normal. So it was an acute anterior granulomatous uveitis. So the resident made the first investigations, which were all normal, and he started with steroid drops with a complete resolution of the symptoms. But 3 days after stopping the drops, he came back with a recurrence of the inflammation. That time, there was a very clear iris atrophy, which did us make the diagnosis of herpetic uveitis. Looking backwards, this iris atrophy could have been detected easily when looking a bit more precisely to the iris in the first picture, which was already deformed. The aqueous tap confirmed the diagnosis and revealed the presence of VZV uveitis. So why is it so important to detect the early signs of an iris atrophy? Because iris atrophy is very frequent in VZV-related uveitis, 25% in the acute stage. It can be graded in 3 types of severity. It can be either only basal or has a sphincter involvement, or it can even be diffuse in 6% of the cases. In this series of proven viral uveitis without corneal involvement, the iris atrophy was even more frequent, also 3/4 of the uveitis. So it can be obvious, like in the second picture of our patient, or it can be very subtle, like in this patient. But you really have to look specifically for iris involvement when you're confronted to anterior uveitis. And it's so important because if you have an iris atrophy, it almost confirms the etiology of the uveitis. In this series, 24 patients had it, and the taps were positive in 23% of the cases for HSV and VZV. So iris atrophy is very specific for herpes infection. What are the other clinical signs that can be helpful? Of course, the corneal involvement. But when I speak of the corneal involvement, I speak of the scars or of the reduced corneal sensation, but not about the corneal edema, because it's not specific to herpes. It's in the context of an ocular hypertension. Every high pressure can make a corneal edema. You can also look at the type of precipitates. All herpetic uveitis have precipitates. Most of them are mutton fats, granulomatous, and they usually have often a pigmented appearance, which can distinguish them from the typical PKs found in Posner-Schlossmann or Fuchs uveitis. What can distinguish HSV from VZV? Of course, the skin rash. Ocular involvement is usually within 30 days after the skin rash, but the skin rash is not always present like in our patient. In fact, in a series of 90 cases of zoster ophthalmicus, 5 patients developed uveitis 6 months to 16 years after the skin involvement. So patient has a lot of time to forget it. Also, if you compare the demographics, HSV is much more frequent in younger patients and VZV in older patients. So that's also a clue. And keep in mind that VZV uveitis is always unilateral, but HSV can be bilateral in 18% of the eyes, which is not that few. So in conclusion, the diagnosis of herpetic related uveitis is very probable if you have a corneal involvement, an iris atrophy, or if it's following zoster ophthalmicus. If you don't have those specific signs, the diagnosis of herpes is uncertain and it can only be confirmed by Menneko's tap. So I thank you for your attention. I hope you learned something and I wish you a good webinar.
So thank you, Angela, Zainat, and Florence for your great presentation. So we now have a chance to discuss the talks we have just heard, and we have had a number of questions from the audience. So the first question is for Angela. You mentioned about corneal scraping. How large should the bacterial infiltrate be before you perform corneal scraping? That's the first question.
It depends. The cases are very different. Their shape, about 3 millimeters, is for me a shape, a large of the corneal infiltrate that suggests to do the corneal scraping. In general, in case of size less than 3 millimeters, I prefer not to do the corneal scraping, but it's different cases by cases.
Thank you.
Maybe I can ask this question to maybe Florence regarding the emergency of uveitis. Basically, uveitis and the acute glaucoma cases intertwine with each other frequently, especially when the patient arrives with high intraocular pressure. Do you have a tool to differentiate those cases, like differentiate an acute uveitis attack from like an angle closure glaucoma? What kind of tools do you use in general?
Well, first, things to look at the angle, obviously, which is
Of course.
Seems logical, but some residents assume that if the pressure is 50, the angle is automatically closed. But that's the first thing. And look precisely for small precipitates, which are not normal, not uveitic glaucoma. Yeah.
Okay. Thank you.
So we have a question for Dr. Zainat. So the question is lancectomy suggested to be better done for both eyes to prevent recurrence in the other eye? And is it of high risk to have a recurrence on the other eye when you have one eye that had angle closure?
Okay, so great question. Yes, I totally agree. There's a high risk of the recurrence in the other eye, since this is just a kind of primary angle closure glaucoma. So the other eye is also fellow eye has a tendency to develop the same clinical situation. So the lensectomy is one of the most important part of the treatment plan. That's for sure. And of course, we recommended cataract surgery for the fellow eye in this patient, but we should keep in mind that cataract surgery should be done in experienced hand in patients with, especially with short axial length and high risk eyes, because these clinical situations can get complicated easily. So I think that's the most important part. And yes, I agree.
Thank you. I think we have maybe just one more question time. So the question here is back to Florence. What do you think of peribulbar steroids in herpetic uveitis with oral antivirals?
Yeah, I use that frequently. Yeah, especially if there is corneal involvement and you're not, you don't want to put too many drops of steroids. So I use that really. And for the other question about the pupil distortion, it's the beginning of the edge distorts the pupil. So yes, it's frequent in herpetic uveitis.
Okay. Well, thank you very much.
I think we are moving to our second section of the webinar, which is on acute painless vision loss. And I would like to welcome our next three speakers. First one will be Dr. Neringa Yurkute, who will discuss transient ischemic attack and amaurosis fugax, differentials and assessment. Dr. Rodolfo Mastropasqua from Italy will discuss artery and central artery and vein occlusions and their acute management. And finally, Dr. Matteo Forlini from Italy also will discuss vitreous hemorrhage, differentials, and assessment. Thank you very much.
Good evening, everyone. Thank you for inviting me to give this talk in SOE webinar series. It is important to know the terminology. And transient ischemic attack, which further I'm going to refer to TIA, is an episode of neurological dysfunction resulting from temporary disruption in the blood supply within the brain, and it's not associated with any infarction or ischemia. If there is temporary retinal ischemia and disruption in the blood supply within the retina, it causes amaurosis fugax, which actually this term falls under the transient ischemic attack terminology. Both cases are acute. They happen due to inadequate and temporal cerebral or ocular blood supply, last from a few minutes to a few hours, and usually fully resolves within 24 hours. Specific imaging studies demonstrate the lack of cerebral ocular infarction. 74 years old female came to the clinic with a history of painless sudden left eye visual loss, which she describes as curtain coming down. The symptoms were associated with expressive dysphagia, and both of them resolved at the same time within 10 minutes. She had a treatment for her general condition, and medications are listed here. Ophthalmological assessment was within normal limits. Fundus examination indicated signs of hypertensive retinopathy. And transient monocular visual loss and amaurosis fugax in the left eye, expressive dysphagia, and likely TIA diagnosis were made. She was further investigated by stroke and cardiology teams, and a few episodes of paroxysmal and atrial fibrillation flutter were identified by Holter monitor. In addition to her previous medication, she was prescribed with clopidogrel, and since then she never experienced similar episodes of signs and symptoms. The clinical picture of amaurosis fugax usually sudden onset, severe and painless visual loss. It can be partial field or full field loss, usually in one eye, which completely resolves within 1 hour. Ocular examination is usually normal. An exception would be seeing the retinal emboli within the vessels. There is a normal neuro-ophthalmological, neurological assessment, and normal vision in the unaffected eye, of course, if there are no comorbidities. The origin for the atherosclerotic plaques travel to the eye can be within the eye, optic nerve, orbits, brain, neck, and heart. As I mentioned, thromboembolism is one of the most common causes and actually travels. The main source for that is carotid vessels. Other causes to lead to TAA and amaurosis fugax would be hypoperfusion, vasospasm, elevated plasma viscosity due to certain conditions, or atherosclerotic cerebrovascular diseases. It is important to ask patients about other comorbidities and other risk factors. Differential diagnosis of transient monocular vision loss is wide and large, but generally not all of them will be urgent and needs urgent assessment and treatment. Talking about TAA, emergent ophthalmologic and cerebrovascular relation is necessary in those cases because there is a risk of stroke following these, which varies from 10 to 15% within the first 3 months. An urgent assessment, investigation, and treatment can reduce this by up to 80%. What we can do in the clinic. Comprehensive neuro-ophthalmological evaluation with the imaging is important. Urgent bloods needs to be requested, as well as urgent MRI and MRA if ICA dissection is suspected, or if ICA stenosis is suspected, then duplex Doppler of carotids. And of course, referral to TAA clinic vascular specialist or neurologist is a must. ABCD2 score, which you can see here on the left-hand side, is widely used for the TAA risk stratification. Patient needs to be given 300 milligrams of aspirin in acute stage, which is followed by 75 milligrams once a day until they are seen in TAA clinic. Of course, patient needs to be advised not to drive till formal assessment. It is important to manage all the risk factors, and if there is a specific TAA etiology identified, then it leads to a specific management. Moorfields Eye Hospital has a TAA pathway for the urgent scenarios and routine scenarios, but due to lack of the time, I'm not going to discuss this. Probably it's going to be available later online, and this is the scheme. So take-home message. All TAA should be treated as medical emergencies as they may lead to a permanent vision loss or ischemic stroke. They should undergo extensive workup in the same manner as those with an acute stroke. And the management of all TAAs is similar and should focus on the stroke prevention strategies. Just don't wait and act quickly. Thank you very much.
Hello everyone, thank you very much for the kind invitation. We know that retinal vein occlusion is the second cause of vision loss worldwide, and we can differentiate between CRVO 10-20% and BRVO 80-90%. We know that the physiopathology behind the vascular occlusion is all regarding the balance of the Birkhoff triad, which leads to vascular occlusion. Therefore, we must consider this risk factor when we try to assess a patient facing this disease. We need to evaluate the patient history, check all the systemic risk factors like blood pressure, blood test, and try to understand which is the cause behind. Regarding the CRVO, we have 2 forms, an ischemic one and a non-ischemic one. The first one is distinguished because the vision is normally really poor. There is a RIPD, extensive hemorrhage, cotton wool spot, and changes at the perimetry and electrophysiology. A multi-imaging approach is fundamental in order to assess this kind of patient. Here you can see a fundus photo with the most peculiar changes in case of CRVO, and the fluorescent angiography is very important in identifying this disease and distinguishing between the ischemic and non-ischemic form. We know that the ischemic type has non-perfusion areas that are greater than 10 disc areas, so we have to use it every time we study our patients. The macular edema is another key factor. We know what macular edema is an imbalance between fluid entry and exit with accumulation of intra or subretinal fluid, and the gold standard is, of course, fluorescent angiography and structural OCT. The latter is useful in identifying the type of edema, so we know that there is cystoid macular edema with or without serous detachment, but also we can have a loss of the delineation of the inner retinal layers, and this is due to the ischemia. The angio-OCT is the last tool available, but is really useful and helpful for our clinical practice. The established issues are that in case of RVO, the foveal vascular zone is enlarged, there is a dropout from the superficial plexus, and then anastomosis between superficial and deep capillary plexi. We can use OCTA also for evaluating the response to treatment. This is a nice example of response evaluated with OCTA before and after treatment with the intravitreal dexamethasone for non-ischemic CRVO. The treatment, if we have a non-ischemic CRVO, with a good vision, we can watch and wait, but we need to be ready to switch to therapy if there is a change to the ischemic form. If there is a bad vision or macular edema, we should consider treatment with anti-VEGF as first instance or steroids as a second instance. Regarding the laser grid for non-ischemic form, we should use it if there is no response to VEGF treatment, but we must use it for CRVO of the ischemic form because this guarantees us to improve the blood supply to the perfused areas and reduce dramatically the risk of neovascularization complications. The retinal artery occlusion is a different disease. We know that the pathogenesis is due to embolism or high cholesterol liver or thrombophilia, vasculitis like Orton, or autoimmune disease like Susak, and all the other risk factors for embolism. We have 4 different clinical patterns, basically non-arteritic with or without ciliaretinal artery sparing and arteritic. And here you can see an example of the 4 patterns. Again, it's mandatory to take care of the systemic risk factors. Otherwise, we cannot help our patient. But in these cases, the treatment is much more difficult because we don't have time. So the fluorescent angiography helps us in distinguishing between the non-arteritic and the arteritic CRAO, as well as the structural OCT, which can give us in the early acute part of the disease and hyperreflectivity, and in the late chronic part, atrophia and hyperreflectivity of the inner layers. The OCTA is very important and sometimes is able to identify the area of non-perfusion better than fluorescent angiography. And here you can see, for example, an example of Susak with the complete restoration after treatment, and you can see how the OCTA was helpful. Regarding the treatment, of course, we don't have time. We need to reduce the pressure, so anterior chamber paracentesis or trying to do ocular massage. If there is an Orton, we need to give systemic corticosteroids, temporal artery biopsy, and treat the risk factors. Thank you.
Hello everybody, I'm Dr. Matteo Forlini, vitreoretinal consultant in San Marino Hospital. My SOI webinar is about vitreous hemorrhage, differentials and assessment. Of course, the main symptoms are sudden painless vision loss with haze in the vision, and also myelesopsia or floaters or photopsia. About signs, you can see red blood cells in the anterior vitreous chamber, a partially obscured view or a totally loss of red fundus reflex if severe vitreous hemorrhage. In case of chronic vitreous hemorrhage, you can see yellow ochre appearance, and you can see also a mild RAPD if it's a dense hemorrhage. About etiology, the most frequent causes of vitreous hemorrhage in adults are proliferative diabetic retinopathy. This is the most frequent cause at all. Or hemorrhagic PVD with retinal tear or retinal detachment, retinal neovascularization. Another cause could be trauma or Terson syndrome, or another cause ruptured retinal microaneurysm or retinal angioma. A very useful mnemonics for vitreous hemorrhage differential diagnosis is the word vitamin D. You have to remember vitamin D, V as vascular, like hypertensive retinopathy or sickle cells. I as ischemic, like neovascularization post-central retinal vein occlusion or branch retinal vein occlusion. T as trauma, Terson or Valsalva. A as autoimmune, like for example occlusive vasculitis, like Ehl's disease, for example. M as metabolic, as proliferative diabetic retinopathy, of course. I as infectious, like infectious vasculitis, N as neoplastic, for example, leukemia, lymphoma, or melanoma, or radiation retinopathy, and D as developmental, like ROP, incontinentia pigmenti, or Norris syndrome. About etiology, don't forget the following causes in children. You have to think about child abuse, for example, shaken baby syndrome, or pars planaris, or X-linked retinoschisis. It's important to make a differential diagnosis with vitritis, and you have different clinical features. First, you have a not sudden onset. It can be associated with anterior-posterior uveitis. You can have white cells in the anterior vitreous, and you have to look for snowball or snowbanks. At US features, you have a more uniform echogenicity. You can see uveal thickening with pars plana exudates or cyclitic bands, also vitreoretinal adhesions or tractions. About management. First, patient's history. You can ask for any ocular or systemic disease, maybe trauma, maybe anticoagulants. Then, slit lamp examination with undilated pupils, considering IOP, iris neovascularization, or RAPD. Then, dilated fundus examination of both eyes, and if not possible retinal examination, you have to perform B-scan, of course, to rule out. So maybe you can find retinal detachment or tractional retinal tears or intraocular tumors. About treatment, if there is evidence of retinal tear with retinal detachment on B-scan, or in case of vitreous hemorrhage with iris neovascularization, or in case of hemolytic or ghost cell glaucoma, you have to perform vitrectomy. But if there is no evidence of tear or retinal detachment on B-scan, you can choose for close observation, suggesting to the patient no heavy lifting, no bending, no straining. Keep head of the bed elevated. It's better to eliminate anti-clotting agents unless medically necessary, and you should evaluate patient daily for the first 2 or 3 days. But again, if there is no non-clearing vitreous hemorrhage, or if etiology remains unknown, you will have to perform vitrectomy as well. A complication can be ghost cell glaucoma. It's a secondary open-angle glaucoma caused by hemolyzed erythrocytes obstructing the trabecular meshwork following vitreous hemorrhage. The diagnosis is made by history of vitreous hemorrhage with IOP markedly elevated and anterior chamber or trabecular meshwork filled with small circulating khaki-colored degenerated blood cells. You can see all that with gonioscopy. And about the treatment, you can use aqueous suppressant agent or glaucoma surgery with or without vitrectomy. Thank you for your kind attention.
Thank you, Neringa, Rodolfo, and Matteo, for these very nice presentations. And now we will have a chance to discuss and take the questions from the audience. There is one question to Dr. Neringa, basically. So the question is, should I prescribe something else in the emergency room in addition to aspirin to a patient with amaurosis fugax, the TIA, etc., if we have a case where the patient has 2 hours to travel to the bigger medical center?
Well, the protocol would be just to give 300 milligrams of aspirins until he or she is being seen in TIA clinic, and omitted and regular antiplatelet treatment if the patient is already on that. If they are already anticoagulative treatment, then continue this. There is no need to give aspirin, and that's it.
Okay. Any questions to Dr. Neringa? Simon, Are you?
Yeah, I think there's a second question in the audience that was for Dr. Follini. I think it's particularly about the retinal tear that was presented in the photograph. Would you like to comment on that, Dr. Follini?
Which photogram you said?
So, Dr. Matteo, from the audience, they're asking you to show the tear that was obvious on the ultrasound, which may not be so convenient now. I'm not sure if you can show it right now, but maybe later on we can email him. His name is the audience is we will email him later on with the sign on it.
Okay.
And there's another question for you also. So the question is, how long is it necessary to wait before performing a vitrectomy in a case of vitreous hemorrhage? This is for you, Dr. Follini.
Okay, good, very good question. So, talking about vitreous hemorrhage without retinal detachment, of course. Okay, so
yes,
the question is if I have a vitreous hemorrhage persistent with a flat retina, usually I'm waiting maybe 1 month, maybe the second month. If I don't see any improvement in the second month, even with the medical therapy like fans, drops, non-steroid drops, if I don't see any improvement after 1 month, the second month, I'm considering vitrectomy.
Can I ask to Matteo something?
Yeah, ciao Rodolfo.
So please,
Ciao, Matteo.
please.
Matteo is a very good friend of mine. A question: if you see a retinal tear with the ultrasound, you go straight to theater, or you just monitor? So you know that there is a vitreous hemorrhage with retinal tear, but not enough view to perform laser. Do you wait few days, strictly monitoring with the B-scan, or you just go in and remove the gel and do the laser?
I would wait 2-3 days, because sometimes in 2-3 days I could obtain a good visualization to perform the laser. And of course, it's better to perform laser
and avoid the vitrectomy.
Avoid vitrectomy. Mm-hmm. So in the best hypothesis, I could wait 2-3 days. I could have a good visualization to perform laser, and that's it. And
sure.
retina remains flat. This is the best hypothesis. Of course, after in the worst hypothesis, if the retina detaches, I have to go to vitrectomy.
Sure.
So it's just an attempt to save from vitrectomy. Yeah. Do you agree?
No.
You agree?
Yes, I do. Even though there are some centers that approach hemorrhagic PVD with retinal tear as a macula or retinal detachment, so they go straight. Whereas in crowded hospital or busy hospital, they do what to do, which I agree. Maybe if you can avoid the vitrectomy, it's better.
I agree. Vitrectomy is, of course, invasive treatment.
Yeah.
So I have one question for Rodolfo, kind of like a segue on it. So trying to be less invasive these days, people are now switching over from fluorescein angiogram to using OCT angiogram. So, in the era of, current technology now, is the fluorescein angiogram still useful in retinal vascular occlusion, or have you all now completely used OCTA instead?
Nice question. So the guideline says that we, as a first approach, we have to perform fluorescein angiography, which is still the gold standard. But we can follow the patient with the OCTA, which is quite good, as I showed, in determining the areas of ischemia and also in seeing the response to treatment. But also because the wide field OCTA that we have, they cannot arrive so peripheral as the fluorescein angiography. So at the moment, a wide field for FA is still the gold standard.
Thank you so much.
Thank you.
Thank you. I think we should move on to the next section. Simon?
Yep, I agree. Yeah.
Yeah.
Let me just see. So, I believe. So we now move on to the third section of the webinar, which is on ocular traumas. And I would like to welcome our three speakers for the evening. So I think it's Cüneyt Osman from Turkey, who will discuss the chemical and thermal injury at the acute management. Michael Zassos from Greece, discussing sharp trauma, corneal lacerations versus penetration, the assessment and referral. And finally, Dr. Vladislav Disnik from Serbia, discussing blunt trauma, hyphema, and first rupture, again, the assessment and referral. So thank you.
Dear colleagues, I'm going to present acute management in chemical and thermal ocular injury, and I have no relevant financial interest. I'm going to give basic epidemiological data and focus on acute management of chemical and thermal ocular injury. Chemical and thermal ocular injury comprises up to 18% of all ocular trauma, and it is one of the most urgent ocular emergencies out there. I'm going to focus on chemical ocular injury from now on because direct thermal injury to the eye is rare, and rapid blink reflex protects the eye from thermal source, and eyelid takes on the majority of the insult with late lid contractures and exposure keratopathy later on. And the acute management is similar to chemical injuries. A patient admitted to ER usually goes through several examination steps prior to receiving a treatment. However, previous evidence suggests that treatment should be prioritized over immediate ocular assessment in case of chemical ocular injury. But who is treating? Usually the first line of people who treat chemical trauma are bystanders, and they are family members or a friend who are non-medical professionals. Later on, emergency medical services and first responders come into the picture. However, they are non-ophthalmologists, MDs, nurses, or physicians in training. So bystanders and first responders have a crucial role in the treatment of chemical ocular injury. Public education is important because our goal is the immediate removal of the offending agent and copious irrigation of the affected eye. Time to initial irrigation has the greatest influence on visual prognosis. Prior to irrigation, disinfecting hands with an alcohol-based hand sanitizer is not recommended because it could cause further irritation if it gets into the eye. And topical anesthesia by a local anesthetic drop is helpful to relieve the symptoms and help with the irrigation. But keep in mind that anesthetic drops should only be used during the irrigation and should not be prescribed to the patient. So how long should we irrigate? Classic teaching tells us that 30 minutes or 2 liters of irrigation is enough. However, current guidelines suggest continuous irrigation until the ocular pH is restored. So we should check for the ocular pH every 30 minutes. And how are we going to check it? An ophthalmic pH meter is very hard to find in ER, but we can find a widely used pH meter, which is in a urine dipstick. The pH box is in the middle, so we have to cut the dipstick and then use it in the fornix. And we need to stop irrigation for 5 minutes for optimal pH acquisition. Use of alkaline or acidic solutions in an attempt to neutralize the chemical burn should be avoided at all costs. And irrigation of a chemical injury should take place at least 30 minutes, but most likely it's going to take more. There are many eye wash brands that are out there for public use, and a number of studies have looked for the best agent for irrigation. And certain solutions containing buffering agents have been proposed as ideal. However, even tap water is an appropriate irrigating solution. So the best rinsing solution is the one that is available. Morgan lens is another important asset that should be used with topical anesthesia to facilitate the irrigation process. But keep in mind that this lens has a disadvantage of not being able to push away the chemical remnants in the fornix because it blocks most of the palpebral fissure. There are many factors that affect the severity of and prognosis after chemical injury, but the most important factor is the time between the insult and the irrigation. Delays in the initiation of irrigation by as little as 20 seconds have been demonstrated in animal models to result in a higher maximal pH at the end. The importance of chemical injuries lies within the limbal stem cell injury that they cause, which leads to ocular surface diseases and which in turn leads to melting, perforation, and blindness. So we learned that chemical and thermal ocular injury is one of the most urgent emergencies in ophthalmology, and immediate neutralization of ocular pH, it has the utmost importance. Thank you.
Good afternoon, this is Michael Tsatos, and I'm going to talk about sharp ocular trauma, corneal laceration, and penetrating ocular injuries. I'd like to thank the organizers for their kind invitation. I hold no commercial interest in anything discussed in this talk. So, from a definition point of view, corneal laceration, corneal penetrating injuries share a very similar mechanism. However, corneal laceration does not involve any tissue loss, whereas corneal penetrating injury does involve tissue loss. Another common differentiation of ocular injuries is between penetrating and perforating corneal injuries, with perforating injuries having both an entry and an exit point. As always in the assessment, you start with a very good history, noting the nature of the injury, the mode of action, the location of the injury, and we should always make note whether the patient was using any protective equipment and the use of prescription or any other type of glasses, because these can be shattered and therefore foreign body glass in this case could enter the eye. Whether the patient is amblyoptic in the injured eye or in the other eye is quite important, the use of medications, and especially tetanus immunization status. The clinical examination, of course, as ophthalmologists, we use a slit lamp. The slit beam does help us with the assessment of the AC depth. We should not forget transillumination, retroillumination. As we can see here, it can help us with the location of foreign bodies in the iris. It's not easily seen. Otherwise, use of fluorescein does help very much differentiate whether the injury is full thickness, so there is communication between the AC and the outside, the environment. As we can see here, the dilution of the fluorescein just proving leakage from the AC. Another telltale sign where the injury is, the corneal injury is full thickness, is the presence of pigment in the wound, suggesting dilation of the iris, and as we can see, for example, here, dilation of the capsule and the lens structures. However, in this case, it is surprising that the intraocular pressure was normal. The reason is it was plugged by iris and possibly a little bit of fibrin. We should be quite careful with the pressure in the eye, avoid gonioscopy and scleral depression for the assessment of the retina, which of course should be done, and it can be done with gentle ultrasonography. In cases of suspecting foreign body, we should have a very low threshold for scanning, CT scanning, orbital protocol, meaning very thin 1 millimeter cuts. And as most foreign bodies are of metallic nature, we should avoid magnetic resonance. So what to do next? Of course, that depends on the injury and the type of injury. However, all patients should be covered with broad spectrum of gram-positive and gram-negative antibiotics, topically and systemically. Superficial laceration, especially centrally, could be encouraged to heal with the use of bandage contact lens, as we can avoid, in that case, high risk of astigmatism of sutures. Peripheral laceration, especially if there is gaping, of course, we need to use sutures, as we can see here. In cases of tissue loss, cyanoacrylate glue, at least as a temporary measure, can be used. We can see here placement of cyanoacrylate glue and a little bit of plastic from the drape that goes directly onto the crater and needs to be covered by a soft bandage contact lens because the surface of the glue is quite rough. In more severe injuries, the patient needs to be taken to theatre with general anesthesia. Of course, these injuries are usually full thickness corneal injuries with or without the presence of a foreign body. In those cases, a shield should be placed on the eye. The patient should be made comfortable and kneel by mouth for the preparation for emergency surgery. I'm sure our anesthetist colleagues are aware of that, but we do prefer general anesthesia because ketamine and sodium calling for sedation do tend to increase the intraocular pressure, increasing the risk of intraocular content expulsion. I'd like to thank you for your attention, and of course, I'm available for discussion and questions. Thank you.
Dear colleagues, thank you very much for joining us to this SOE ophthalmology webinars. My name is Dr. Djinic, and my topic today is blunt trauma. One of the most important things when we see the injured eye is in the management process is to determine the type and the extent of the injury. How can we achieve that? By ophthalmological evaluation, which includes the history, how the injury occurs with the visual function testing and different kind of examination with the help of imaging techniques. Hyphema is the most commonly diagnosed pathology. The incidence vary depending on the type of the injury, and it usually clears spontaneously within the days throughout the trabecular meshwork. It is very important to say that according to some studies, more than 50% of the eyes with trauma-related hyphema showed some types of the posterior pathology. Evaluation of hyphema, the slit lamp is the best tool to identify it. Visual acuity and intraocular pressure can vary, and it depends from the quantity of the blood inside the anterior chamber. Various methods are presented to describe the size of the hyphema. It can be presented in millimeters, it can be presented in percentage, or even in a clock hour when we use the meniscus of the blood compared to the corneal limbus. Treatment of hyphema is usually medical. We use psychoplegic mydriatics to reduce the pain in synechia, topical corticosteroids to reduce the inflammation, and anti-glaucoma treatment if it is necessary and if we have an elevation of intraocular pressure. Aminocaproic acid or the TPA can be added in order to reduce the incidence of rebleeding or to speed up the clearing of anterior chamber. No patching and no hospitalization is needed, and in severe cases, surgery can also be the options. Complications of hyphema include recurrent bleeding, corneal blood staining, and glaucoma. So what is important when we speak about the hyphema? It is important to rule out, first of all, the systemic disease, to try to prevent the corneal staining by lowering the intraocular pressure. And one of the most important fact is to exclude any other ocular damage. On the other side, rupture of the globe is the most severe type of the injury. Rupture sites are rarely at the site of the impact. It is usually at the limbus, at the equator, behind the extraocular muscle insertion, lamina cribrosa, or the site of the previous site surgery or any other site. So when we see the patient with injury, which is caused by blunt trauma with substantial momentum, if we found in a history that that eye has a previous ocular surgery, that it is high myopic patient, if we found out the significant visual acuity loss, even no light perception, usually lower intraocular pressure and afferent pupillary defect, all of these facts can lead us that suspect that this is the case actually of the rupture of the globe. Other anterior or posterior segment signs actually vary, and depending from the force of the blunt object. Strands of the vitreous, which are covered with fresh blood pointing in one direction, can actually lead us to the site of the rupture of the globe. We must evaluate every eye specifically, and not just follow the protocol, and we must close the wound as soon as possible in order to prevent prevent explosive choroidal hemorrhage. So when we see hyphema and rupture and compare it, hyphema is usually caused by force which is not so extensive. It usually medical treatment is in most of the cases enough, and the most important thing is to rule out any sign of posterior damage with the help of different imaging techniques. On the other hand, rupture of the globe is very extensive. It's damage of all of the structure. We must take care of occult multiple ruptures and to try to prevent secondary complication due to tissue prolapse and scarring. Of course, imaging techniques are helping us to confirm that, even sometimes explorative surgery, and the treatment is immediate surgery. Thank you very much for your attention.
Thank you, Junaid, Michael, and Vladislav for your great presentations. We now have the chance to discuss the talks we have just heard. So we have a few questions here. First question is about the chemical injury. So my question is that in situations where water is in short supply, would you have any other preferred substance to irrigate the wound? And also a second question, what is the role of amniotic membrane in chemical injury?
Can you repeat the second question, please?
Yeah, the second question is, what is the role of amniotic membrane in chemical injury?
Okay. For the first question, of course, any irrigating solution that is around the neutral pH can be used. For example, usually we can use even milk. However, there is a problem with that. The pH of the milk is a little acidic because of the lactic acid in it. However, it's close to 7, so we can use whatever we have in order to neutralize the pH, because usually the chemical agents that are around us are in the wide range of pH, like close to 1 or more than 9. So we have to use anything that is available. For the second question, of course, amniotic membrane is a very important asset for the treatment of chemical trauma. There are many advantages to it, because it has antimicrobial properties, it has anti-inflammatory properties, it has tissue reforming abilities because of the cytokines in it. So it is a very good asset, but of course, prevention is more important than the treatment in this case. We use amniotic membrane or autologous serum tears for the treatment, and we use it if the epithelium is not healed clearly. But again, prevention comes first, and that was the main idea of my talk. Thank you.
Thank you. So this question is for Dr. Sasso. So in case of traumatic cataract, shown like in the picture of the corneal perforation, how long do you usually wait after the primary repair before you consider secondary surgery, such as the cataract surgery and vitrectomy?
Yeah, so there is a little bit of a debate whether you go ahead and you operate the cataract at the same time as the primary surgery. Of course, it makes sense to do the cataract itself if there is, for example, a foreign body in the lenticular tissues. It depends a lot on the access and the presentation of the patient, whether there is a tiny foreign body, for example, that is quite superficial, and the whole trauma is causing a little bit of cataract. This can be diverted to a few weeks when everything is normalized, and the eye looks a lot more set. Number one priority is fixing the globe, the integrity of the globe. And number two is fixing everything else. I do appreciate that there might be a little bit of a uveitic response to that, and that can be controlled and treated until everything is a lot more set for the eye theater and the team to go ahead with cataract surgery. So to summarize, it can be done in one go. A lot of centers do prefer to do it separately, especially if, for example, the initial trauma is quite superficial, and then to do the cataract surgery after 2 to 3 weeks.
And then I think we have one last question for Painless left. So is there increased risk of causing an acute secondary glaucoma if we use cycloplegics or mydriatics in patients with a large hyphema?
Well, we didn't notice that, because when we see that that kind of patient with a quite large hyphema, we usually prescribe some eye drops in order to lower the pressure, even if sometimes it's on the borderline, just in order to prevent that something can happen because of the widening of the pupil. But we're not using long-acting mydriatic. We're just using tropicamide or phenylephrine, just to trying to play the game, to leave the pupil to play, not to make synechia, to prevent of forming the synechia because of the constant size of the pupil, let's say. But we didn't notice any problems with the pressure because of that.
Okay, thank you very much.
If I may say one more thing, there might be, of course, a combination of mechanisms. For example, there might be a thermal injury associated with a sharp injury, or a chemical injury associated, let's say, burst pipe with a foreign body. So I think all these thoughts can be slightly combined. Thank you.
Okay. So shall we move to the last section? Okay. So last section, fourth and last and final section of the webinar is on orbit, optic nerves and their palsies. I would like to welcome our next set of speakers. Our first talk will be given by Dimitra Porteleu. She's going to discuss preseptal and orbital cellulitis, pediatric theme assessment and management. Michael Stormley from Denmark will discuss ion and nion and their acute management. And Nina Jovanovic from Bosnia will talk about third nerve palsies and their acute management. Thank you very much.
Good afternoon, everyone. Thank you for staying almost until the end of the webinar. I'm Mimi Porteleu. I'm a consultant oculoplastic surgeon, and I just want to say that I'm very, very honored to be included in this SOI webinar. We're going to talk about children, and in particular, we're going to talk about preseptal and orbital cellulitis in children. And I'm going to start by stealing the words of the great Jeffrey Rose in Moorfields. He says that it is very evident that a child is not just a small adult. And this essentially means that we should not approach and treat a child the same way as we would for an adult. Evaluating a child, though, can be quite tricky, quite difficult. And that's because children have better things to do. They don't want to give you good history. They don't want you to examine them. They just don't always cooperate. And sometimes parents are not making your life easier. So it's quite tricky getting to a diagnosis for a child, but it's quite a pleasant thing working with children as well. What is an orbital cellulitis? So orbital cellulitis is an infection of the soft orbital tissue posterior to the orbital septum, in contrast with the preseptal cellulitis, which is a soft tissue infection of the eyelids anterior to the septum. There's the well-known Chandler classification of the periorbital infection, which has different types, from 1 going on to 5, 1 being a preseptal cellulitis and 5 being a cavernous sinus thrombosis. If we're talking about a preseptal cellulitis, we should have a clear event that led to it. If it's a bite from an insect or a stye, a chalazion, or an injury. We should have something. If there's no evidence of an etiology, then we should always proceed with imaging. The preceptal cellulitis is more common overall. It can be seen in children under the age of 5, and the prevalence is more or less the same in little girls and little boys. Orbital cellulitis can be seen in all ages with an average of 7 years old. It's more common in male, associated with sinusitis in most of the cases, and more common in winter. The difference between the two is quite obvious because usually with preceptal cellulitis, you just get eyelid edema present. But with orbital cellulitis, you get a child with edema, warmth, tenderness of the eyelid, fever, systemic illnesses, malaise, and then you get vision changes, ophthalmoplegia, proptosis, chemosis, limited extraocular muscle movement, reduced visual acuity, and you might get an RAPD. The pathogens. The most common ones include Streptococcus and Staphylococcus, but Haemophilus influenza is quite common in children. And obviously, if it's a fungal infection, Mucor and Aspergillus should be considered. Differential diagnosis, edema from an allergic reaction or an orbital wall infection from sickle cell anemia, or proptosis from pseudotumor or exophthalmos related to thyroid eye disease in children and young adults. Etiology, as said before, 90% of cases, ethmoid sinus infection that extends into the orbit. It could be a dacrocystitis or a dental abscess that leads to the orbital cellulitis. It could be previous trauma or periorbital surgery, a foreign body. Fungal infection should be considered in this case, or it could be a septic embolization from bacteremia. If it's a preceptal cellulitis, you don't need to do anything further. If it's an orbital cellulitis, you should proceed with blood tests, wound cultures, and imaging. The most appropriate imaging is a CT scan of the orbits and the paranasal sinuses. And if there's evidence of sinusitis, you should include ENT. You should work as a team because usually the drain should be done from the sinuses as opposed to be done through the orbit in this case. You should get cultures. And obviously, if you do get surgical drainage, you should get cultures obtained from the drain. What is important is what's written and underlined in yellow, that the clinical improvement does not correlate accurately with repeat CT scan analysis. And it may take up to 3 days for the scan to improve after we've drained the abscess. So we should not panic. We should just wait and see. If the clinical condition of the child improves, then we shouldn't rush into going into surgery again. So if all that exists, we should manage as orbital, which means admit, start broad spectrum antibiotics, and check in 24 hours to see if there's an improvement. Surgical management in cases over the age of 9 with frontal sinusitis, large abscesses, recurrent episodes mostly, and evidence of acute optic neuropathy. If there is a sight-threatening condition, we should intervene quickly. Usually surgical intervention is less likely in children under the age of 5 because the infection is caused by one organism and then IV antibiotics usually are enough to control the infection. Complications include recurrent episodes, which are mostly related with non-bacterial organism, collagen disorders, or any type of immunosuppression, cavernous sinus thrombosis. It can be a life-threatening condition, intracranial infection, optic nerve damage. This is a very busy slide, which is more like an algorithm of what we've discussed before and what we need to do in cases of orbital cellulitis, admit and treat. And in cases of preceptal, we can send home with oral antibiotics and then review in 24 hours. And this is a very, very nice slide from the East Midlands Emergency Medicine educational media, where it tells you exactly what to look for and where to learn from. So these are a few resources that you can read from. It's really good for trainees just to guide them through how to deal with orbital cellulitis in the emergency room. I just want to thank you for your attention. These are a few photos, not from Switzerland, but from Greece. We had a pretty rough winter this year, so I'm just sharing a few photos with you. Thank you very much for your attention.
Thank you for letting me do this small talk on acute management of anti-ischemic optic neuropathies. As many of you know, anti-ischemic optic neuropathies is a major cause of blindness. We have a non-arteritic form, which is thought to be due to hyperperfusion of the optic nerve. We have an ataritic form, which is due to inflammation and subsequently thrombotic occlusion of the short posterior ciliary arteries. Both conditions leave the optic nerve with ischemia. We can subdivide ischemic optic neuropathies into different groups. We have an anterior one with papilledema and a posterior one. In this talk, we're going to concentrate on the non-arteritic form and the arteritic anti-ischemic optic neuropathy. As many of you know, the incidence of the arteritic form is highest in the Scandinavian countries. The clinical presentation of the arteritic form and visual features include double vision, cranial nerve palsy, amaurosis fugax, and visual loss due to anti-ischemic optic neuropathies. This article represented 106 cases presented of having giant cell arteritis. 36% presented with ocular symptoms. Risk factors for visual loss is old age, male gender, hyperperfusion, a positive biopsy, and delayed initiation of glucocorticoids. A more rare presentation is when you have hyperperfusion of the occipital lobe. Here we have a case presented with bilateral vertebral artery vasculitis, which presented with photopsia on both eyes. To secure diagnosis, especially of GCA, can be difficult. This is due to the nonspecific nature of symptoms. Investigation along with clinical insights produce the highest sensitivity. We have the non-arteritic form and the arteritic form. The arteritic form, the patient will normally be older, a mean age of about 74. There will be symptoms like headache, jaw claudication, and polymyalgia rheumatica. The patient will present with a pale, swollen disc. And in the non-arteritic form, the disc will normally be hyperemic, and you will show a discal risk at fellow eye. In the non-arteritic form, biomarkers will be normal and also the biopsy, where in the arteritic form, we will have elevated biomarkers and a positive biopsy. We manage these cases. There is no proven effective treatment of the non-arteritic form. Aspirin has no effect, although if you have risk factors, it can be a good thing to start the patient on those. It is important to quit smoking and look for other risk factors, especially sleep apnea. And in a very young patient with NION, it can be a good idea to look for optic dystrusion. In the arteritic form, it is of paramount importance to start the patient on glucocorticoids immediately, and afterwards start tampering the patient. There's no evidence for aspirin, although like in the NION, it's important if there's risk factors, it may be a good thing to start the patients. A new treatment like tolizumab can reduce the toxicity of glucocorticoids. So the take-home message is that GCA is a medical and ophthalmological emergency. Fast-track pathways reduce the morbidity, such as visual loss in GCA, and non-invasive imaging and clinical expertise can be used for first-line diagnosis of GCA. Ultrasound is non-invasive and fast, and tolizumab achieves remission with significant glucocorticoid sparing. Thank you for your attention.
Good afternoon. I would like to thank the organizers for the invitation to present my topic on the cerebral palsy and acute management. The main goal of this presentation is to review different etiologies and clinical manifestations of medical emergency that presents with oculomotor nerve palsy. The function is divided to somatic, affecting voluntary eye muscles, and parasympathetic, that supply ciliary muscle and the sphincter pupillae. Paresis may be partial or complete. Signs of complete palsy are photoaptosis, inability to adduct, infraduct or supraduct, dilated pupil, and delayed reaction. The most common causes include raised intracranial pressure that compresses the nerve against the temporal bone, posterior communicating artery, superior cerebellar and posterior cerebral arteries aneurysm, cavernous sinus infection, trauma, diabetes, MS, myasthenia gravis, GCA, while in kids the etiology is somewhat different. In general, deep nerve vasculature is affected by ischemia and affects fibers that go into external eye muscles, while aneurysm, compressing superficial parasympathetic fibers, affects pupillary response, resulting in dilated pupil. Different clinical presentations varies with the location of the affected part of the nerve, which dictates level of emergency in general. Lesion of nucleus in midbrain causes usually bilateral defects, paralysis of the superior recta, and ptosis. If a patient has ipsilateral pupillar dilatation, it may indicate dorsal rostral damage, often caused by ischemia, in which case we refer patient to internal medicine and neurology. The lesion of oculomotor nerve fascicles is caused by some degree of insult and causes complete or incomplete palsy, cerebral ataxia, contralateral involuntary movement, asynergy, and tremor. Lesion of the suprachoroidal space causes palsy with fixed dilated pupil. The most common known etiology is a posterior communicating artery aneurysm, which is a true medical emergency, while another medical emergency is intracranial hemorrhage in this case. Differentiating between lesion and the sinus versus fissure can be challenging and sometimes described as sphenocavernos's syndrome. This can be caused primarily via direct invasion or secondary via intracranial or intraorbital lesion compressing these areas, most commonly with meningiomas or painful ophthalmoplegia known as Tolosa-Hunt syndrome. Usual etiologies of lesion within the orbit is trauma, masses, inflammation, or infiltrative processes. Next, I will present two cases of both male patients, one presenting with ischemic process, which is a non-medical emergency, and the other medical emergency. So the first one is a case of obvious cerebral palsy of the left eye with typical deficit in eye movements and unaffected pupil. We see left adduction, supra and infraduction that are limited, and patient has pronounced ptosis and unaffected pupil. He reported no pain and no diplopia due to ptosis. Imaging methods were obtained and the diagnosis of exclusion was ischemic vascular etiology. The second case shows a male with not so evident signs of adduction and infraduction deficit and only mild ptosis. However, pupil was dilated and unresponsive. He complained of diplopia and periocular pain. This was a medical emergency asking for prompt imaging, which showed nasopharyngeal cancer compressing the nerve. Post-contrast coronal MRI shows an enhancing tumor centered at the clivus with partial right cavernous sinus invasion, and the palsy was the only neuro-ophthalmic feature. So diagnostic and imaging procedures are tomography and angiography, MRI and MRE. However, the gold standard is the digital subtraction angiography or SDA. Angiographic studies also can be used throughout acute intracranial pathology, especially if ophthalmoplegia is associated with pain. So as a take-home messages, I would like to say that palsy without pupil involvement is most likely to be related to ischemic process, but compression and inflammation should also be considered. Evaluation and management vary according to patient's systemic illnesses, age, and associated symptoms, and basic workup, other than imaging, should include vital signs, complete blood counts, sedimentation rate, CRP, and comprehensive metabolic panel. Thank you for your attention, and these are my references.
Again, I'm checking the Q&A if there is any question to the speakers. But till then, I may ask a question to Dr. Dimitra Portelou. So regarding the hospitalization of the pediatric, like preseptal cellulitis in a very young age, maybe like under 2 years of age, do we have a different approach, or like when do you hospitalize your pediatric patients when they have suspicion for orbital cellulitis or they have preseptal cellulitis?
So generally, from my experience in the, thank you for your question, first of all, Murat. So from my experience in the UK, we tend to just, admit young children, even if it's a preseptal cellulitis, to give IV, just to make sure that they're doing okay, and just check after 24 hours to see how they're getting on. So generally speaking, even if we're not worried that it's an orbital to start with, we tend to admit and give IV at least for 24 hours.
Thank you. Simon, you have any comment on that? Or maybe Nina? Or maybe Michael can comment? If you deal with pediatric patients at all.
I tend to do what Nina, what Mimi does.
Yeah, exactly.
I defer to the experts, I would say.
Yeah.
Thank you, Simon.
So I do have a question that's in the panel. Actually, for Nina, actually, I think Nero asking, would the pediatric version of a third nerve palsy versus the adult version of a third nerve palsy, the approach or the management approach would be any different? Nina, would you like to answer that?
Yeah, absolutely. Well, first of all, it depends if a pediatric case comes with a congenital or acquired nerve palsy. And if it's a congenital, and we would of course assume that is like some birth trauma, which is the most common cause of congenital causes, despite of maybe previous beliefs that can be like brainstem development issues. And then if it's acquired, then it's most often caused by some kind of virus or other infection. And maybe even after vaccination, like measles, mumps, and rubella vaccine caused some sort of association with third nerve palsy in kids. So I would first approach to these pathologies, and then I would probably do imaging because it's less frequent that it's a medical emergency like it's in adult. Especially if with or without pupillary involvement.
Okay, thank you. So question to Michael, for giant cell arteritis, you mentioned about the need to do a biopsy. What is the optimum time to perform the temporal artery biopsy in these cases?
Well, you can, actually as fast as possible, but you can do a biopsy about 1 week to 14 days. That would be kind of the window. It's more important if you want to do PET scans and so on. There's a narrow window there, so only about 4 days. So for temporal artery biopsy, of course, the faster the better, but you have a bit more time when doing the biopsy. You can also see healed lesions on the biopsy as well. So yeah.
Mm-hmm.
And I may ask a question to Michael also, if you allow me. So what is the role of the PET scans, FDG PET scans, in the diagnosis of like temporal arteritis or giant cell arteritis? And second question, very shortly, is there a role for hyperbaric oxygen therapy in NION, not in arteritic type, but non-arteritic type?
Yeah. First, the role of the PET scan, if you have access to a PET scan, the giant cell arteritis, you have inflammation in the big arteries. So it's also aorta and subclavia and so on. And actually, you normally see the inflammation here. So if you use the PET scan, you can see the inflammation in these large vessels where you don't have access to those when just doing a biopsy. So that's kind of the important role of the PET scan. We do experience when we do PET scans that we also see that the vertebral arteries are normally involved, and you can't find them on the biopsy. The second thing is that you can also find cases of differentials like unknown cancer and so on. So that's the role of the PET scan. So yeah, you can get more information about all of the arteries, not just the temporal artery. And yeah, I don't have that much information on the NIO and the treatment using hyperbar. Yeah, so.
Thank you. Simon, would you like to add something? Anything?
I think Neri has one more question. I think we
Yeah,
probably
okay,
can push. Yeah, we can push that.
Yeah,
Yes.
okay. So to Michael's again, do you use high-dose IV steroids for arteritic ion or prefer oral therapy?
In our center, we normally use oral steroids and high doses. But I know that yeah, it's different. Sometimes you can use IVs. Of course, if you have a case where it's a bilateral and yeah, you can't do anything, then we would probably try IV. But normally we use high dose oral.
Okay, thank you very much. I think there are no further questions, and we are also our time is almost up. So I want to thank all our presenters for sharing their expertise, and to all of you who for your continued support of SOE. I would like to thank the audience for listening us and providing their support to us. So Simon.
Yeah, so again, thank you very much. Today's webinars has been recorded and it will be available via the SOE website shortly. There will be a short survey at the end of the webinar. Please take time to complete this so that we can know how we can improve our next sessions. I hope today's presentations are helpful. And again, thank you all for your time today, and please stay safe and healthy in this time and day. On behalf of my co-moderator, Murat Hasanoglu from Koç University, Istanbul, this is Simon Fang from UCLA. We are signing off. Thank you.